Welcome to the NewlyMeds podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys? Welcome back to another episode of the NewlyMeds podcast. Firstly, I just want to start out with a little bit of an apology, an introduction to this episode, but recently life had its way of doing life. Had a rough couple weeks. We weren't able to get an episode out the first of this month. Obviously, we weren't even able to get an episode out on the 15th. We are working very diligently to get episodes back out to you April 1st, April 15th, trying to get this episode that we're recording now out as soon as we can. The pro side to this is that in February, I hope you all have had the chance to listen to Zach talk about the wonderful things that the sepsis protocol is doing in Pennsylvania. It's really been a game changer, it sounds like, for their system. I've had the ability to talk with him recently on how that pilot's been integrated and being implemented in their system and being used. And I've heard some really great things about it, not just from him, but from people I know in the surrounding areas. So if you haven't listened to that in our brief absence, I would urge you to do so. Secondly, I want to thank Dan, because this podcast really couldn't get done anymore by myself. I've had a lot of life events happen. I've been in school for a long time, and running this on my own was something that was getting really overwhelming. In this brief absence that I've had to take, Dan's really done a lot of the legwork for me to keep this podcast up and running. He got today's episodes really in the works, been reaching out to me on a personal basis, which is nothing new. Him and I have always done that for each other for many years now. But he really is the best co-host I could ask for. He's a big part of the brains behind this operation. He's the tech guru, if you guys didn't know that by now. I don't know if I look young. Maybe I do, but I am not tech savvy by any means. I don't even know how to Twitter anymore, how to tweeter. I don't even think it is Twitter, but that shows my age. Yep, that shows my age right there. But Dan's really done a lot of the footwork here. So Dan, I want to thank you for that. And I'm really glad that we finally have the opportunity now to sit down, talk to each other. We got the opportunity to catch up, but even just talking about today's episode, I think we have some really awesome things in store. So thank you for doing a lot of the footwork on this. And with that being said, Dan, you and I today are going to talk about something that's pretty unique and pretty impactful in EMS, and something that I really challenged with when I was a brand new EMT, but more so as a brand new paramedic. I want to talk about some of the buzzwords that we always hear: low volume, high acuity, and also just because you've been doing it for 20 years doesn't mean you're good at it, or just because you've been doing it for 1 year doesn't mean you're bad at it. And so today we're going to dive into a few things of what that actually means. So Dan, I want to start talking to you about something that I really struggled with when I was a brand new paramedic. I came out of school in a very busy system, having been an EMT in a very busy system, and acquired a lot of knowledge with being a paramedic in a very good paramedic program. I loved where I went to paramedic school. I had great clinical exposure. And I wouldn't say that I came out thinking I knew everything, but I knew what the right practices was, especially in a unique time frame in EMS where practices were really changing right in front of us. And I saw a lot of talented medics who've been doing it for a long time actually start to see their practice shift. And some of the things they weren't doing for the last 5, 10, 20 years, now we're doing them. Or even some of the things that they were doing, now it's like, we shouldn't do that anymore. And so I kind of came in, not ruffling feathers, not shaking things up, but with this box of tools in my hands, a bunch of knowledge that I acquired, and this question of, how do I do this? How do I do it well? And how do I do it without really pissing people off that have done it differently or think that their way is still the best way? And I think that was a really huge challenge for me. While I kind of didn't know at the time, there was some research going on that kind of debunked this. So Dan, why don't you tell me a little bit about your experience, and then we can dive into the literature that says, does doing something for 20 years make you really good at it? Or does doing something well and putting a lot of effort into that said thing for a short amount of time make you better at it? I kind of want to break this down with you. So Dan, give me your thoughts on the topic.
Well, and I think we had a very similar experience coming out of paramedic school, in that we were working in the same system at the time. And I do think it is a very fine line to toe with trying to implement more correct practices, trying to create and bolster that environment of evidence-based medicine versus I've been doing this for 20 years. This is how I've always done it, and this is how I can plan to continue to do it. And so I think it is a fine line of trying to advocate for that, and as you said, to not piss people off. But I think there is a healthy way to piss people off, because a lot of times that's what is needed for change to come about. And I'm not advocating for going out and, intentionally, causing drama, but challenging these old dogmatic ways that we've done things in the past. And well, it's always worked for me, so why wouldn't it work now? Well, there's evidence-based medicine, there's articles, there's research that shows that that's not the case. So I think when I was fortunate coming out in that you had come a little bit before me, and a couple others before me as well in our system specifically, that had kind of already started advocating for that shift and advocating for that environment on our shift and on our platoon specifically. We were both very fortunate in that our local management was on board with that. So I think I might have had a little bit of an easier experience than you. As I'm sitting here thinking about it, there wasn't many people before you, specifically on our platoon, specifically on our rotations, that were of the newer medic variety and kind of looking to make those changes. And so I think when we start thinking about this, it's actually interesting, because I saw this article in JAMA that we're going to talk about. I saw this probably shortly after it came out, and it got me to thinking, when you guys read this article, we'll have it linked as always. When you guys read this article, it's kind of obvious. It makes sense. It's not anything groundbreaking or anything that suggests something that you weren't already expecting to hear. But I think number one, it gives us statistical evidence that shows what we've been saying, what we've been thinking. But two, this coupled with some of the other things that we're going to talk about really supports that environment, that atmosphere of continuous learning, of practically challenging yourself, academically challenging yourself, and getting those good reps in. So Will, if you want to kind of talk about that article a little bit, and then we'll kind of dive into some of these other topics with some other articles as well.
Yeah, Dan, I think you made a great point. And it was definitely, I want to circle back a little bit. When I first got my medic, there were a lot of very experienced paramedics on our platoon. And Dan was on my shifts. You heard him just talk about it. And I wouldn't say that I started to ruffle feathers, but I had my own, like every paramedic ever, I had my own way of thinking through patients, thinking through calls. One of the things that our system had was trauma. And I think one of the slowest things to change in EMS was the way that we managed traumatic injuries and traumatic patients. And working on a platoon with really experienced people, I saw a lot of medics giving IV fluid, for example, in a lot of patients with massive external hemorrhage. And we now know that putting normal saline through a 14 gauge wide open, typically putting 2 liters of normal saline through bilateral 14 gauges wide open, especially, is probably not the most beneficial thing for our trauma patient. And I learned this in school, not only like, hey, don't do this, but this is why we don't do it. This is how it actually affects our oxyhemoglobin curve and sort of hemodilutes the blood and lessens our oxygen carrying capacity, as well as some other things. To put it in really layman's terms, you're not going to fill up your truck that takes diesel with vegetable oil, or you're not going to take your truck that takes diesel to a Tesla charger and expect it to charge and move anywhere. The same way that if we don't give our body blood, it's probably not going to do anything good. And so that was why there was this huge push for whole blood in pre-hospital settings. And I've been so fortunate to have worked through this last 5-6 year period as a paramedic where blood's really been pushed out to a ton of services nationwide. And I think that that's amazing and incredible. And in my small section of the world, I was still seeing some of the old school practices continue while I was a medic and pushing for evidence-based, interventions to be carried out appropriately. So much so that I would still receive QA remarks saying that, why did you not initiate fluid resuscitation for your traumatic patient? Because we were still in that kind of archaic way of thinking that someone QAing my charts was thinking maybe I wasn't doing something appropriate if I wasn't doing a liter, if not two, on my massive external hemorrhage patient. And so kind of pushing through that and pushing for better practices was something that I did only for a short period of time before Dan became a paramedic, that he saw me do, and kind of he got in at an awesome time, and he was working as an AEMT, and we, even as a system, started to push for more evidence-based things. So I think that that was awesome. And diving in more so, Dan talked about this JAMA article that we're going to dive into. And so I want to pull that up briefly and talk about kind of my take on it. So Dan, you spoke about this JAMA article, and some of the findings that I saw were very similar to what I just spoke on in the traumatic sense. And something that hits close to home, mainly because of the location that we're in, is in Pittsburgh. And I actually have a really close friend of mine who went to paramedic school with me, who works for the city of Pittsburgh. And I get to hear kind of firsthand, maybe I don't want to call it inside information, but I always get the scoop from him on some of the really cool things that the city of Pittsburgh does. And they got some brand new equipment recently. But in this article, it talks about a really huge finding that I saw, that I was talking to Dan about, that stood out to me. And it said that for every 3,649 severely injured trauma patients treated by the city of Pittsburgh EMS, 359 total clinicians between 2017 and 2021, for every 5 additional patients that clinician saw in a year, there was a 10% decrease in a risk of mortality within 6 hours. So what that said to me was that paramedics who are getting exposed to these trauma patients, that are putting in the time and the effort to research best practice, there is a 10% decrease in mortality. Now, this article doesn't directly say that these paramedics are researching the best practice on their days off, or researching the best practice while they're at the station and implementing, best evidence-based measures for these trauma patients. But what I do know about the city of Pittsburgh EMS and a single clinician who works for them, I think it can apply to the system as a whole. They do a really good job at breaking down high acuity calls with their provider. If something was not done that should have been done, it would have been brought up in a conversation. And if something that was done inappropriately maybe should not have been done, such as a fluid resuscitation that doesn't really meet the requirements for fluid resuscitation, that would have also been discussed. And so for every 5 patients that experience some form of trauma that one clinician sees, you can decrease mortality by 10%. It doesn't sound like a lot, but in the world of medicine, where things are done in this very minimal percentage realm, 10 is a ton.
Right.
And it was an insane statistic that stood out to me in this article. Then what else did you see from this article? Because for me, that was such a huge finding, but there was some really key, awesome pieces of evidence that were brought up in this literature. So why don't you walk me down your take on it?
Well, absolutely. And you kind of alluded to this, and I do want to just state that yes, this article is observational. It's not causal. We're not saying, and the article's not saying that this is the only specific thing that that plays into that percentage. But I think number one, this leads to more research. This was initially building on a previous study in the Annals of Surgery, where it was that study basically just found that higher trauma volumes equals better patient outcomes. And so this was kind of trying to drill down further into the actual numbers. And I would imagine that this would lead way for even more research into that as far as the experience versus actual volume. This doesn't necessarily drill down to the years of experience that each of these clinicians had, but I think what this article is saying and what we're ultimately saying on this episode is that, especially for the folks that are listening that are new or are starting their career in EMS, whether it's an EMT, a paramedic, whether you're in the hospital, whatever level you are, I think a lot of times we think, oh, just because we're new, that 10-year provider has better experience than us. And they might have better experience, sure. But that doesn't necessarily mean that just because they have the years that they've gotten those reps. And we'll talk about that a little bit more in the different types of systems. But with this article, in addition to the statistic that Will had brought up, I do want to point out that yes, this is primarily focusing, or not primarily, this is focusing on trauma, but I think we can make that bridge to medical as well. The core concept of frequent repetitions with XYZ procedure, XYZ presentation can certainly bridge to medical as well. I think that especially in it's 2026, the amount of research that's being done in the medical field, but also the amount of effort that's being put into education is unlike anything we've ever seen before. And so I think that gives us as new providers, us as experienced providers, hope in that. Will and I were talking, and we'll talk about it a little bit later as well. You know, you can intubate Fred the head all you want. And while that's good for muscle memory, and I'm not saying that we shouldn't do that, I do it routinely. The ability in the very near future to bring in actual real high fidelity simulation, incorporating virtual reality, other different types of training tools that will actually bring meaningful, legitimate repetition to these lower volume services and to the high volume services as well, will only add to that bank of repetitions that a provider has. So you can start seeing people with 6 months of experience that have meaningful repetition and meaningful muscle memory of somebody that might have taken, 10 years to obtain. If we're looking at it, 25 years ago, they might have, it might have taken them 25 years to obtain that. So I think when we look at these articles, I think the primary thing that it's saying is simply somebody who has 20 years. I think a lot of people expect them to have the quote unquote more experience, but that just isn't necessarily the truth.
Yeah, Dan, something that you sent me that I think applies still to this day, if not even more so now, was a piece of literature from 2009 in a Virginia EMS agency. And I'm going to backtrack a little bit. So Dan just recently spoke about how, you kind of lose some of the skills in short speak here if you don't use them. And everybody who listens to the podcast knows that recently I still hold all my certifications as a paramedic. I still work as a paramedic. Technically, I work as a PHRN, but I identify as a paramedic. I am a nurse, but I am not a full-time paramedic anymore. I'm a full-time cardiac ICU nurse. And it's been awesome. I've had a ton of awesome opportunities. I've learned a lot. And one of the things that you get in the hospital that you don't get in EMS is, I don't know if spoiled would be the word, but it's the word that I'm choosing is I get spoiled. I have in the ICU physicians that are waiting for me to ask them questions. For direct patient care, I have respiratory therapists that are always on the unit that are helping me. I have not set up my own CPAP or BiPAP in a minute. I have not intubated a patient in a minute. Every single time I work a shift with EMS, I get on Fred the head. Is it the same thing? No. But I do know and recognize that my skills degrade over time. And when I was a full-time paramedic, I was intubating people in a higher volume system. I wouldn't say frequently, but I was getting exposed to it, in a decent volume. And not that is a flex or anything like that. It's just a skill that I had exposure to. that I've lost over time. And I can probably say that I am recognized not as good of an intubator now as I was maybe 5 years ago. Maybe I'm better because there's been technology improvements, but I just haven't had it on the live patient. Some of the skills I've been able to keep. One of the things that, at least in my ICU, a lot of nurses shy away from is putting in IVs. We are also spoiled with central lines and swans, cortices, venous sheaths, femoral sheaths, you name it, we can probably have it or put it in. Peripheral IVs are still very much needed, but sometimes get overlooked. And ICU nurses, just at least where I am, don't have the exposure to putting them in. Luckily for me, they know that I was a paramedic and I am the first person they ask, hey, can you go put an IV on this patient? So I've been able to keep that skill quite frequently because I do it a lot. And so one of the things that this article sent that Dan, showed me was from a long time ago, but I think it applies more so probably even today. But it's the age old thing that is said when I got into EMS, I've been doing this for 20 years or whatever. Oh, you don't know this because you're brand new. And I want to see more data debunk this, but it's just because of how anecdotal the comment is, I think it's really hard to actually get concrete evidence. But this article really sheds a lot of light onto it. It says that paramedics who are in a low call volume EMS system, less than like 50 ALS calls a month, don't get enough real patient exposure, and that this can lead to skill decay. So what does that actually mean? Like if I'm not running, what is a high acuity ALS call? And I think that that is really the term that's up to debate. But in my eyes, it's getting an ALS patient who requires multiple therapies. I need to take serial 12 leads on them, establish IV access, do some sort of medication intervention or titration that involves correcting some disease process. If it's respiratory, maybe I'm putting them on BiPAP, giving a steroid and magnesium and albuterol. Maybe they're CHF and I'm doing BiPAP and nitro paste and IV nitro, all these new things that are coming. Maybe it's a trauma patient that I'm giving whole blood or TXA or intubating or drilling an IO or using point of care ultrasound, all the awesome things that I've seen come to EMS in just the last 3 years. Those are some really great ALS patient exposures. It's not the non-cardiac chest pain that you do a 12 lead on to downgrade to the EMT because they just got hit in the chest with a baseball. Maybe you should be keeping that as ALS. I don't know what your personal practices are, but it's moderate to high acuity ALS calls. And I think when you don't get enough exposure to that, your skills do degrade. And I think that this article did a great job at shedding some light onto that. And to me, it answers that question of if you've been doing this for 20 years somewhere that just doesn't give you the exposure, maybe you are still a very, very talented medic. And I think that it's all up to just personal behavior and practice. And so if you're putting in that work, if you're using Fred the Head, if you're getting a cadaver lab, if your system pushes you to do simulations and quarterly studies and written exams and table tie discussions with your medical director, I think that you definitely could be in a lower volume system and be a very well equipped and well trained paramedic. On the other side, I think someone who's a brand new paramedic can be just as well equipped, if not more equipped, when they are exposed to high acuity patients on a regular basis. And in my own personal experience, I can remember, and I know Dan can remember because we broke it down, the very first call I had off orientation as a medic by myself was a pediatric cardiac arrest. The very first call. I wasn't given a class 3 sick person. I wasn't given an ALS refusal. I wasn't given a generic chest pain. That's what was thrown at me. I had myself and an EMT, and that was it. Police I knew was coming. Fire I knew was coming. I knew that I had Dan and some extra help that would be there if I needed them, and they were indeed there when I needed them. But for the first few minutes, it was me and my partner, and that's it. And that's what I was exposed to. Again, I'm not saying this as a flex, but I am saying that that exposure to multiple high acuity patients over the course of my career, I think has made me a stronger healthcare provider, whether it be paramedic or nurse. I think seeing and being exposed to these really sick patients and understanding how to treat them, not just, give this because that. Why am I doing this treatment? Why does this patient require this specific intervention? Doing my own research, talking to very talented people who know those answers, seeing these disease processes over and over again. No patient presents the same. No two patients present alike. And even the same patient with the same disease process might present a very different way the second, third, fourth, 100th encounter you have with that specific patient. The key is that exposure to high acuity ALS patients and understanding why the interventions you are performing are being performed, I think makes you the strongest provider possible. So in all that long yap that I just said, what does it actually mean? To me, it means that if you are a driven person and you are a driven healthcare provider, you can be phenomenal with 1 month, 6 months, 1 week, fresh out of paramedic school experience. If you are doing all those things in a high acuity system, the same way that you can either be a really talented or lesser talented paramedic if you've been doing it for 20 years in a system that doesn't expose you to the high acuity and frequency of calls with ALS patients. And I think that that's something that I really struggled with at first because everybody kind of looked at me like, who is this guy? And Dan remembers it. I would come in doing things that no one else was doing.
No,
And
absolutely.
just because I researched it on my own, like I think Dan remembers, like I was big on the terbutaline. Him and I would joke about it to a T because I don't remember any other paramedic using it, but it was in our bag. And I made it a point every shift to get in my med kit and know what that medicine is and why I'm giving it. I would not allow myself to use a medication that I did not know certain things about. And I was like, why are we carrying this terbutaline? Like, they don't really talk about it in medical school. Not every agency carries it. And then, people talk, I worked during COVID and people talked about, yeah, well, we didn't want to, neb patients during COVID, but I was using it and I loved it and it worked really, really well. It does still work really well. And I use it to this day for a lot of patients in respiratory distress. And no one else was using it. But there were some other medicines or treatments or just changes in my practice that I was doing that no one else was doing. And I think that's the important thing is if you can justify it, if you're doing it safe, if it makes sense, knowing the why and knowing who to ask on why you're doing this is the key. And I was brand new and I got a lot of stray side wandering eyes on who is this guy? He's only been a medic for 1 minute doing all these things. And Dan was one of the first people to come to my defense and be like, hey, like he might be a brand new medic, but he is more talented than some of our vets. And I always appreciate Dan for saying that because he knows that I won't say it. I will still say I am not. Him and I had a very recent conversation and I said, I am not that guy. But Dan was always pushing for me to say like, he is good. He's safe. He knows what he's doing. And he really, really cares about his patients. And that's one thing I will, not humbly shy away from. I might not be the smartest or the best or the most talented, but I really care deeply about taking care of human life. And I think that's the most important thing and why this matters so much and your own personal drive. But I think that having that exposure to high acuity patients helps a lot with that. Dan, that was a ton, and I know you're itching to talk. So take it away.
Well, I have a couple of things. I'll circle back as well since you've been doing a lot of circling back. But no, I think one of the things that we routinely say is that some of the smartest medics, I just had this conversation with my partner the other night, and I know that we've had this conversation before, and I've had this conversation with multiple people. Some of the smartest and best practiced medics are brand new medics because the information is still fresh. They have just been hounded 1 year, 2 years, depending on what obviously your program is. But for the past 1 to 2 years, they have been hounded with repetitions. They've been hounded with clinicals. They've done ER rotations. They've done OR rotations, RT rotations, ICU rotations, PEDS, OB, on top of, the countless hours on field shifts. They've had these repetitions. And yes, the information is new, but it has been so freshly studied and so aggressively, hopefully, studied through the academic process that honestly some of the best medics are these brand new medics coming out of school, because a lot of people hit that wall where they're fresh out of school and then they're like, okay, well, I've learned that and I'll get back into studying, and they don't make that continued studying a priority. And then we get into that, essentially we fall back into that trap where we're 5 years, 10 years, 15, 20 years in, and it's like, okay, well, I was really good at what I did when I learned how to do it, and I'm just going to keep doing it that way. And so I think, again, shameless plug for just continuing education, continue researching, continue listening to, even if not our podcast, listening to podcasts, listening to whole, whatever you can get your hands on to keep learning the next steps. Medicine is ever changing.
Mm-hmm.
And that's inevitable. We're going to continue to learn more about the body. We're going to continue to learn about how different medicine and different interventions affect the body. And we're going to figure out what the best course of action for any of these disease processes, injuries, etc. We're going to figure out what's best for these things.
Absolutely.
And I think when we think about it, with the thought process of continuing those reps, a lot of times when, especially the most important skills that we need to perform, it's not a figure it out in the moment type of thing. This isn't something that, oh, well, I'm going to hope that one time that I did that in paramedic school is enough that I can remember and hopefully I can make it through. If there's something you're not 100% sure that you could do right now, you need to be practicing that, because you never know when you're going to need to do that right now. And I think that brings that into kind of one of the things that we've both been talking about and kind of hinting at is the whole rural versus urban divide. And that, yes, a lot of what we are saying, you can't control your call volume, or you shouldn't be able to control your call volume. We might need to have a different conversation if you're causing calls, but you can't control your call volume. What you can control is where you work, potentially. What you can control is what effort you put in when you're not on calls. And this is in no way, shape, or form to say that urban is better than rural, that rural is better than urban. This is not a competition between the two, but statistically speaking, as we've already talked about, more volume equals more competency equals less skill decay equals higher. It's positively correlated between confidence and competence. As you are more competent, you are more confident, and those just go hand in hand together. So with our rural services, how do we make those reps? Well, first of all, I know in our service that we had worked at previously, Will and I together, I always was a big proponent, a vocal proponent, that new EMTs, new paramedics should go to the city. We had a very split service where we had very urban stations, we had very rural stations, we had suburban stations. We had honestly a really healthy mix of different types of systems all within our company. That company being giving that opportunity that you can kind of select, if you will, where you're going to work and practice. Now, again, I understand that that is probably the exception, not the rule. Most places where you work, you're going to work in one of those three categories, and you're not going to have as much flexibility of what type of volume you're going to see. But I always was a big proponent of that the new providers should be going to the city, seeing all these different types of calls, seeing all these different types of patients, getting all of these different exposures and repetitions, and then move yourself out. If you wanted to go to a suburban or a more rural area, that's fine. But at least getting that early base of high repetition, high volume, and getting that early and kind of solidifying those things that you just learned and that you just obtained coming out of school, when we think about the formative years of a toddler and young adolescence and how formative that is, it's the same concept in your employment, especially with medicine. Having those early good foundational habits, those good foundational practices early in your career only just bolsters your ability to continue to grow in the career. So I know, Will, you probably have some thoughts about that too. But yeah, so my challenge would ultimately be, if you're a new EMT, if you're a new medic, if you're a new, if you're in the hospital, you're a new RN, whatever the case may be, go somewhere where you're going to get that volume. You can go to the vacation station later, but do that aggressive work up front, do it early, and continue to challenge yourself. Yeah, it might be a little less pay, it might be a little worse schedule, but that benefit that you're going to bring to yourself professionally, and as a result to the patients that you are treating and caring for, is profound, honestly.
Yeah, Dan, I want to emphasize what you said greatly. Firstly, I may be in the very limited category. I think everybody in EMS got to go through the city. One, the exposure is great. I primarily work night shift in an urban environment in a city. I think those high volume areas are great. You got to go through them. You have to really be exposed to patients. A conversation I had with an EMT the other day, they were struggling at recognizing lung sounds. I credit the only reason me being good at lung sounds to this day is because I was exposed to a lot of patients, not even sick patients. And I just made it a point to do a full head to toe on them. And a full head to toe for me includes heart and lung sounds. And so you get good at just listening, like what is a normal lung sound? What is, just a very subtle rub? What's rhonchi, coarse, fine crackles, all the different things. And I would just listen to lung sounds religiously on every patient. So I do think that it's awesome to have the ability to go through the city. Not everybody does, but I think that if you have a city close to you and they're hiring, it's just great exposure in EMS to go through a urban system. So I wanted to emphasize Dan's point on that. The other thing that I wanted to do was dive back into the data that we've been talking about and kind of throw a question back to you, Dan, as we continue to discuss this. So this article study that came out of Virginia was just an experimental study, and there were two groups. It was like an action research design. There were 5 medics in the one group, 4 in the other, and the 5 paramedics practiced 2 ALS skills at the start of every shift, and the other group didn't do any additional practice. And then they compared the real world success rates of these procedures that they were practicing. It's a small study. They didn't find any measurable differences. What they did find was that the paramedics who regularly practiced the skills were more confident and had a greater perceived readiness. And so that just means that they felt like if they had to, they could do the skill. What this study shows me is that they're practicing very high acuity skills with low volume. I don't think anybody is going to practice 2 high acuity skills at the beginning of every shift and that shift go out and do them. A great example is a surgical cricothyrotomy. Very high acuity. You could practice it at the beginning of every single shift. You most likely are not going to cric a patient that shift, or maybe ever in your career. But you may be more ready to do so if you practice it all the time. And you probably are going to be confident in that skill. Is it the same as doing it on a real human? No, absolutely not. We all know that Fred the head is not the same as intubating a human being, but you have a greater perceived confidence. And most likely you have the recognition and the confidence and ability to perform critical interventions in a timely manner and not question whether you should be doing them. And I think that that is key. And it's not something that this study even looked at. What they did look at is that confidence can affect your decision-making, speed of intervention, and willingness to perform. So kind of what I just said, if you're more confident and you do that skill more often, you're probably going to do it and implement it faster than someone who isn't as well-versed. That doesn't mean you're going to be better at it. I would anecdotally say that somebody who does multiple needle decompressions in a year is better at it than somebody who's practiced it on a dummy multiple times a year, because human anatomy is very different. But they would still probably both be very good and competent at the skill compared to someone who's never done a a needle decompression on a human and never practices that skill. And so I think that that is a very huge distinction that this investigative study found. And so, Dan, I want to throw it back to you with what you think about all this, because in my mind, this study revealed to me, and it doesn't, the stars don't align for everybody. But if you aren't being challenged where you work, and maybe your work isn't challenging you, maybe they're not saying you need to go and intubate Fred the head every month. Maybe they're not a service that is saying, we're going to put you in an OR and you're going to work with an anesthesiologist or a CRNA and you're going to intubate people before they go for an operation every quarter. And they give you that opportunity. They're like, you don't have a choice. Guess what? You're not on the truck today, buddy. You're going to the OR and you're intubating with an anesthesiologist and you're going to learn their practice and you're going to get really good at this skill because one day we're relying on you to perform this skill. If you are not somewhere that's doing that for you, I would urge you to, A, when you have the ability, go somewhere that pushes you to be the best provider you can. And or B, if you can't leave your service or you don't want to leave your service or life's, that's the whole reason we're recording this episode now is because life has its way of just doing life.
Yep.
Network. Find like-minded individuals who push you to be the best possible provider you can. Dan has pushed me my entire career, along with multiple other individuals that I can mention, to be not only the best paramedic I can, but to pursue further education. Go to nursing school. Like tell me, hey, you're too smart not to do this. And pushing me to consider other higher forms of education, pursue doctoral degrees, because they know my own abilities, probably more so that I even know my own abilities. They give me more credit than I give myself credit for. And you need to find individuals like that that push you to be the best. You don't have to be in a system that runs 100 ALS patients a month or more. Does it help? Yeah. Does it expose you to it? Yeah. Do I love picking up in the city still because I'm a per diem employee and I really love EMS? And even though I work in the hospital, I still put my time in on the street? Yes. I pretty much don't pick up at the vacation stations at all. I pick up in the city. To my friends in the city that are watching, I will disclose I do pick up princess shifts. I am a nurse. After all, I am a princess. I do not do 12 hours in the city anymore. Kudos to those who do. But I did do my time. And I still go back to the urban setting because there's just so much exposure that you can have. And I love it. I really do. And I think it's important. With all that being said, Dan, what is your take on it? Do these skills really increase your confidence level to the point to where it makes a difference? And how do you go about, for you, filling your cup in the way to being the best provider that you can? Because I know that you recently did that and you and I have this discussion all the time.
Well, absolutely. So a couple points that I wanted to talk about. And I think I will start with saying that I believe that this goes with the confidence as well as the muscle memory to do things not only efficiently, but correctly and competently. I recently had an intubation, and on the video review of that, obviously all intubations get video reviewed. I didn't realize it in the moment, and when I had intubated the patient, I blew the bulb up right below the cords, and it was like basically almost on the cords, very high up, and I did not catch that in real time. And that got me thinking too, when I'm doing these tasks and when I'm doing these practice sessions with Fred the Head and doing these different educational, requirements and additional education and additional practices, I know a lot of times, myself included, a lot of us do the important part. Yes, I put the bougie in, I slid the tube over the bougie, and now that patient is intubated. And I would challenge that, regardless of how silly it seems, do the whole process. Make sure that you don't just have everything sitting there. Have your actual bag, or a replica bag, if so we're not taking stuff out of our truck that needs to be ready to go, but have a replica bag. Pull the items from the bag so that way you know where they are. do every step the way that you would do it in the field. Blow up the bulb. I'll be honest, a lot of times prior to this last intubation, a lot of times I would be that one. Okay, I threw the bougie in, I threw the tube in, and okay, I'm done. But to challenge yourself to do all of those steps only further solidifies the entire process. Intubating somebody is not just putting a blade in their mouth, putting a bougie in their airway, and putting a tube in their airway. That is not an intubation. There is so much more that goes into that, and we all know that. That's not what we're here to talk about. But doing all of those little extra steps really solidifies that as well. And so I think that when we are coming out of paramedic school, nursing school, EMT school, if you're already working somewhere, kind of like exactly what Will was saying, if you're already working somewhere, either find a way to challenge yourself to get those repetitions, or if you are in the market, that should be something that you should be really looking into is the atmosphere and the support from the system, support from management to provide these types of opportunities. I'm very fortunate that where I work now, every quarter we have required airway. Every quarter we have a required in-person training on a whole host of topics. We have monthly computer training, and we have an educational room in our base that has anything that you want, that is just open for you to use and to practice and to, get these reps in with that. In addition to that, one of the, I don't want to say this was, a deciding factor, but one of those things that just added to my decision to go where I'm at now is we had an academy coming through new hire orientation where we spent 2 weeks in the classroom and we learned protocols and we went over airways and we went over vents and monitors, etc. But not only did we do all of those things, we had the opportunity, even the EMTs came with us to the cadaver lab where we did everything. We did OPAs, NPAs, correct BVM ventilations, intubations, needle decompressions, surgical airways, where we had this exposure on a cadaver. And I think, a lot of people pay, a lot of physicians pay good money to get this exposure that my company offered to us as part of our, initial employment. And I know that, not a lot of places have the ability to do that. And I'm not saying that, if you work somewhere that's not the case, that's not a good place to be. That's not at all what I'm saying. But finding a place of employment that values education, that values training, that values getting these repetitions in is incredibly important, especially if you're looking for a new place of employment. That is incredibly important considerations to take when we are looking at these different services. And again, I say that, I know sometimes exactly what Will was saying is you might have to do this on your own. You might have to make these networking connections and go out and find these opportunities on your own, or with like Will said, with a group of like-minded people where, I'm very fortunate that I have a lot of training that is not only required of me, but offered to me, that I don't really have to do a lot of thinking about when my next training is coming, because I have that kind of handed to me. I know when Will and I worked at the service that we worked at together, that's not the case there. And so we would have to find these trainings a lot of times on our own, but they're out there. It is almost it's almost FDIC time and EMS World time, and Resus X is coming up, and all of these different things are coming up that are just phenomenal networking experiences, phenomenal educational experiences, and can get you those both physical and academic reps that we genuinely need.
Yeah. On my side, I want to close out here by emphasizing what Dan just said. You do not have to be at a service that provides all this to you. Does it help? Absolutely. You don't have to do any of the thinking. They're like, we want you to come in a quarter and intubate and simulate and do all these things. If you're not somewhere that does that, right now, by even just listening to what Dan and I are saying, you are taking step one to being a better provider. You're seeking it out on your own, because I can assure you, no EMS agency, to my knowledge, and I do think that I would know, is currently advertising the NewlyMeds podcast. Hit me up if you want to. But you are taking the first step. The other thing that I will say is sort of a naive comparison to make, but I think when you look at the big picture as a whole, it makes sense. But these EMS agencies, to me, when I look online somewhere and they advertise that their paramedics, before ever being hired, have to pass a written exam, have to go through a 2-week resuscitation academy or a 2-week paramedic academy, even if you've already been a paramedic for 140 years, you have to go through their academy. You could have been a paramedic forever, and they're like, hey, you're new to us, you still go through our academy. To me, that screams awesomeness, because they want their providers to be trained at a high level and that they have high standards and expectations. Services that won't even give you an interview until you pass a written exam, it speaks volumes. And I have taken a lot of standardized tests in my time. The NCLEX, the NRP, the NREMT, and the EMTP, and the NRP for neonatal recess, all of them. I've taken all these pocket cards exams, all the fun stuff. Written exams kind of stink. Like, I don't love them. Sometimes the questions are hard as they're meant to be, and you want more information. But a human life in real time is a test. This patient care is the exam that you're taking. You have to be able to think. This isn't some experiment, as much as yes, it is. Medicine's a practice and all that. But when you are given the process to be successful, with prior to hiring exams and academies and quarterly sims and all this, those agencies, in my search and experience, advertise it. Because to the general public, when I'm sitting here at my house, I want the EMS agency that lists online that their providers take exams and sit down with physicians and go to conferences and have quarterly simulations and interact with cadavers and do all these things, and they post it on social media and are proud of it. I want that paramedic responding to fix me. And it's the same way that you probably want a lawyer who went to Harvard defending you in a criminal case, maybe over a lawyer that went somewhere you don't know. That's not to say that the lawyer from Harvard is better than the lawyer from Joe Schmo Community College. He very well may be way worse than that lawyer, but he was given resources that exposed him to high academic levels. And so, is it naive to say that, like, if you're a Harvard lawyer, you're the best lawyer in the world? Yeah, absolutely. But did you gain more exposure to have the ability to be really good at your job? Probably. And it's the same way that these agencies that advertise, our paramedics do X, Y, Z, ABC, than the agencies that don't. Does that mean they're better paramedics? No, 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 no. But does it mean that they're put in a position to be paramedics, better paramedics? Absolutely. And I think that's the key differentiation that you have to make. Where are you getting your exposure? If you're doing it on your own, that's step one, and that's phenomenal. But it's even better when you are somewhere that supports your own learning that you're doing by yourself, and then pushes you to do more. Like, hey, we know you listen to these podcasts. We know you practice evidence-based medicine. We want you to do really well. We do these quarterly simulations that you have to do here. We want you to do them, but you have to do them. And then they make this super supportive environment. It's not a test. It's like a learning space, and you do really cool things, and you sit down and you talk about evidence. You talk about all the things that we love. In my experience, those paramedics, those nurses, those doctors are pretty damn good at their job. Do you have to have all that to be good at your job? No. Does it go a long way in helping? Absolutely. And that's my 2 cents on all this. And I think that the literature that we post in the show notes will support that, not concretely. A lot of this was just some banter, some anecdote, which we try to steer clear from on the NewlyMeds podcast. But I think it's really important to tie these points together with some literature. Is it concrete data? No. Are we ever going to have concrete data on practicing surgical crikes every single day, making you better at them? No, because it's just such a low volume skill that it's hard to actually tell if that practice implements in real world. And so I just think it's important to bridge those connections, and being somewhere that supports you and encourages the best practice, I think goes a long way in making you the best provider rather than being somewhere that may not give you that exposure, in my opinion. Dan, I'd
Yeah.
love to hear your thoughts.
No, absolutely. I think exactly what you said when we're talking about a subjective topic such as confidence. Yes, there are measures for confidence. There are measures for these types of things. But at the end of the day, these measures are also subjective, right? So exactly, you're exactly right in saying that it's hard to get concrete objective data when we're talking about things such as confidence and readiness and self-perceived ability to do a task versus the physical ability to actually do the task, which that is measurable. But like you said, we want to, while we are talking about a relatively subjective topic, we do want to at least offer some of the research that shows that this isn't just Dan and Will saying these things, other and fill in the blank coworker, because we all say these things, but there is studies that back these points up. And between these studies, like we've said, the skills will fade if you are not practicing them. Volume does matter, whether that volume be something that you're going out and seeking on your own, whether that be something that your company is supplying for you, or whether that is something that the service just naturally has as far as actual volume. Whatever that is, practice it's non-negotiable. We have to be seeking this out or practicing in some way or the other. And we'll get ready to wrap up here, but I did want to get one more take from you real quick, Will.
Yeah, of course.
For the services that do both 911 emergency calls as well as interfacility calls. I know there is a lot of, especially with the newer providers, there's a lot of disgruntledness. There's at times hate for being with a service that has to do these interfacilities, and we'll leave the politics of that out of it, and we'll leave the utilization of 911 for interfacility, et cetera. We'll leave those conversations to another time. But I wanted to see what your thought was, Will, even though I'm pretty sure I know what your thoughts are. But I challenge you, if you are in a system like that, I challenge you to still find this as a repetition. Will brought it up earlier. I also, when I teach an EMT class, you don't get good at tasks. You don't get good at assessments. You don't get good at different aspects of this job without doing it. My EMT classes, I tell them every patient, it doesn't matter what it is, do a full assessment, listen to lung sounds. Even if they're normal, if they stub their toe, listen to their lung sounds. The more normal lung sounds you hear, the easier it is to hear not normal lung sounds. And then you can start breaking it down from there. And I hold this to the same standards with interfacility transfers. It is still a patient. It is still a patient with a medical complaint, with a medical problem, theoretically. And that is still a repetition, if nothing else, for an assessment, if nothing else for lung sounds, if nothing else for talking to a sick human being. No, you're probably not criking your interfacility transfer. You're probably not, depending on what type of service you work for, maybe, the patient crashes and you're intubating, but you're probably not intubating your interfacility transfer. But I know the service that I work at, the service that Will and I used to work for, that doesn't mean that you don't take some really sick people. I routinely take people in respiratory failure on BiPAP. I routinely, maybe not as routinely, but I take patients that are intubated. I take patients that are on pressors and are on, various drips, etc. these are all still repetitions, and understanding and getting the most out of each patient contact, whether that be a stub toe on a 911. That stub toe 911 call is not a repetition unless you make it one.
Correct.
Just like that interfacility transfer is not a repetition unless you make it one. Make the most out of our time, make the most out of our opportunities to interact with patients. So that way we can just continue to build that good foundational base.
Yeah, absolutely. To speak to the interfacility side of things, I have a few key points that I want to hammer down as we wrap this episode up. One, exactly what Dan just said. Every patient encounter is a repetition. And when you look at really simply sports analogies, pro athletes, they are so good at what they do because they do it all the time that it becomes second nature. And so a good example is professional golfers. Golf is a very hard sport. If you've never done it, I would urge you to go out and swing a club and see exactly how hard it is to hit the ball in the middle of the face almost every single time, which is what these pros do. But they do it over and over and over and over again so that it becomes second nature. And they practice so much and hit the ball so many times that they become very good at this. If you assess a patient so many times throughout your career that you know exactly what normal is, just like in golf, you know when you're hitting that sweet spot every single time, that you know if you are 1 or 2 grooves off, which you hear these pros say, like I was a groove high, groove low. When you have so many reps of patient care, you inevitably will become very, very good at providing patient care. And I think that interfacility is one of the best places for that for 2 simple reasons. One, as an EMT, it's a great opportunity for you to go and get exposure and listen to BLS patients, lung sounds, assessment. And in that, it is the best opportunity for you to talk to a physician and a nurse on their thoughts because they are sending the patient out and they should be at bedside. Why are we sending this patient out? What are your concerns? When you step into the realm of ALS interfacility transports, I have had far sicker patients going ALS interfacility than I have had in a 911 setting. Interfacility transport, especially at the ALS level, is most often used to send a patient from a lower level of care to a higher level of care. And there needs to be a very talented team to do that. And that's where like ALS critical care transport comes into play. More often than not, those patients are very, very sick. Now, those providers pretty much do interfacility all the time. They're not running 911s. They're dedicated, very strong, talented providers at bridging the gap between a low tertiary community hospital to a level 1 trauma center, more often than not. But when your service mixes the two, that to me, I am human like everybody else, is where I got caught with my pants down because I was always like, I'm a 911 medic. I'm a 911 medic. This interfacility is stupid. I don't want to do it, blah, blah, blah. And I get to the sending hospital and that patient is crumping. I mean, crumping. And they just want to get him out. They don't want to keep that patient longer. They called you so that you could help them to move that patient to a high level of care. And then I'm standing there like, oh, I don't know what to do, but the receiving hospital does. But now I need to bridge that gap. And so that's where you can really get caught with your pants down. And so I would urge you to make the most out of every repetition, but do not discount those interfacility transports. And please do not, because I am guilty of it, of being like, I'm going on this interfacility. Those patients need you. They really, really need you because they are going from a low level of care. And it is your responsibility to get them to that higher level of care safely. That's the key word, safely. These interfacility transports are no joke. Just like your 911 patient relies on you to take care of them from 0 to level 1 trauma center safely, that patient relies on you to go from the tertiary community hospital to the level 1 trauma center safely in the same manner the 911 call does. Just because you're not responding to it, lights and sirens, And just because they already have an IV established and maybe an ET tube and some chest tubes or whatever it may be, doesn't mean they aren't just as critically ill, if not more so. And so you just cannot discount those repetitions. The same way that professionals in any aspect never discount a single rep. Take every rep with a purpose. Learn from it, grow from it, know what's normal so that when you don't see that normal, when you're hitting it a groove low, you know it innately, immediately when it happens. When you walk into that hospital room and you see an interfacility and you're like, whoa, this is bad. But I have seen normal and I've seen bad, and I'm going to do a really good job at stabilizing this patient and getting them that next level of care so that they can get the care they deserve. The same way that when you walk into a 911 setting and you see that patient in severe respiratory distress, because you've seen so many normal respiratory patients, so many moderate respiratory patients, and so many severe, you walk in and you're like, hey, I'm about to cook because I've practiced this. I've become good at this. I've become confident in this. And that's the distinction. And that's why Dan and I are here talking about it today, because that's what matters. These small reps are not small. You don't need to run the mega code to be a good medic. You got to start from learning from the small ones and growing from them so that when that one mega code does happen, you got to cook. And I think that's my point on it, Dan. I think that, to me, is what really makes the strong providers out there.
Yeah, I love it. I think that's a good ending right there. We're about to cook. With that being said, I know today's episode was a little bit more like Will said, it was a little bit more anecdote, a little bit more conversational. We're just excited to be back on the mic with you guys, and we're excited to get back on track here with the format that we have already put out there. And so I'm excited. I know the next episode, we're going to be back into the weeds with some more research and with some more detailed actual medicine. If there is anything that you guys do want to hear, please reach out, and always make sure that you're checking out all the different socials, because we do have, we've been kind of hinting at it, but we do have a new series that's going to be coming out that's going to be exclusive to our social medias. You're not going to hear that on the podcasting platform. So if you're not already following those, make sure you are, because we'll be putting out some more information on that, and that'll be coming out very soon as well. But I think with that being said, if you don't have anything else, Will?
Yeah, Dan, I don't have anything else on my side.
Well, it's great to be back, and we will catch you guys on the next episode.